Yeah, good morning, students. Yeah, so good morning to all the third year comedy students. So this is Dr. Sunil Kumar. So as you know that in the last class we were discussing about diuretics. Yeah, let's continue the discussion of diuretics today by beginning with classification. Yeah, let me share the screen. Yeah, I hope the screen is visible to you. Yeah, please pay attention. This is very, very important. So classification of diuretics. So here diuretics can be classified according to their strength or potency into three different categories. First category of diuretics are very, very strong, which we call it as high potent diuretics or high ceiling diuretics, or which we call it as loop diuretics. Yeah, you can see here. So this is the first category of diuretics that is called as high ceiling or loop diuretics or high potent diuretics. Okay. And the word loop, it indicates the site of action. These diuretics are going to act on ascending limb of loop of Henle. Okay, as they are going to block certain transport system which is involved in the absorption of salt and water or sodium and water, and thereby by blocking the transport system they are going to prevent reabsorption of sodium chloride as well as water, and and thereby they will increase the excretion of sodium and water. Okay, and that particular transport system that is inhibited by these diuretics at the loop of Henle or ascending limb of loop of Henle, it is called as sodium potassium chloride co-transport. So this is a transport system which is blocked by high ceiling or loop diuretics. Okay, so that will be discussed. That will be discussed when I uh, when I discuss individual diuretics. So this will be taken in detail. And coming to the different drugs available in this classification, so the basic ring uh, here is sulfamoyl. Okay, so all the drugs are sulfamoyl derivatives, and you can see the structure of one of the drug that is called furosemide, or which is a very uh, famous drug, or which can be used not only in congestive heart failure, which can be also used in many cases of poisoning, where poison which is absorbed in the systemic circulation has to be eliminated at an earliest through urination. Okay, so furosemide or furosemide can be used. So you have bumetanide, you have toracimide. Furosemide, bumetanide, and toracimide. And this is the structure of sulfamoyl derivative. This is the structure of furosemide. Okay, I don't want to enter into the structural aspects. If you want to, I mean to say that compare the structure of different high ceiling or loop diuretics, you can refer any textbook like Wilson and Giswald or any medicinal chemistry book, you will come across. Okay, so high ceiling diuretics are the diuretics which are the most effective among all the diuretics, and they are going to act at the ascending limb of loop of Henle, and they are going to act by inhibiting sodium potassium chloride co-transport system, which is going to absorb large amount of sodium and water in the ascending limb of loop of Henle. Okay, and all the drugs are going to block the transport system, which is called as sodium potassium chloride co-transport, and thereby they prevent the reabsorption of sodium and chloride along with water. So thereby they will increase the excretion of sodium and water. Drugs available are furosemide, which is also called as furosemide, and we have a brand name Lasix. So Lasix is nothing but it is also a furosemide. So bumetanide and toracimide. Okay. Next comes medium efficacy diuretics. So medium efficacy diuretics are which act moderately, which will increase the urinary output in a moderate manner. So medium efficacy diuretics, they are further classified as benzothiazidines as well as thiazide-like diuretics. Thiazide-like diuretics. Got it? So here, medium efficacy diuretics, they are also going to block a particular transport system, especially at the distal tube, distal tubule. Okay, let me show you a structure here. You can see. So what we discussed just now, that is loop diuretics here. So loop diuretics, they are going to act here. As I mentioned, they are going to act on loop of Henle here. This is the site of action of loop of Henle. So all these ions, sodium, potassium chloride, which are reabsorbed. You can see the arrow mark, which are reabsorbed here. So the reabsorption is blocked by loop diuretics. Thereby, so sodium, potassium chloride, water will be carried uh, all along the length of the nephron, and finally they are excreted in the urine. Okay, so that is what happening. And the site of action of thiazides, okay, which act on here distal convoluted tubule, just here. So this is distal convoluted tubule. This is the site of action of thiazides. They are going to block a particular transport system here in the distal convoluted tubule, and they are going to block the reabsorption of sodium and chloride. And that particular categories of drugs available in medium efficacy diuretics, they are benzodiazepines, or what we call it as thiazides. Thiazides. What I have shown you right now, the site of action where thiazides are going to act, that is DCT, distal convoluted tubule. Okay, and here you have wonderful drugs which are the one of the widely used drug even in hypertension. Even in hypertension, thiazides are given as the first choice. Okay, so you have hydrochlorothiazide, benzthiazide, hydroflumethiazide, and flopamide. Flopamide. These are the drugs which will have a basic thiazide ring, which will have a complete thiazide ring. Okay, and this is one of the example I would like to show you. That is hydrochlorothiazide. Hydrochlorothiazide is a widely used thiazide diuretic. Okay, so next coming to thiazide-like diuretics. They are not completely thiazide. They have some other attachments also. Means they will have some heterocyclic rings attached to it. Okay, I can say that they are not purely thiazides. They are partially thiazides. Okay, and in that you have chlorthalidone, metolazone, zipamide, indapamide. Okay, so these drugs are thiazide-like diuretics, which are not purely thiazides. Okay, so third, the mechanism of action remains the same. Even these drugs will also act on distal convoluted tubule. Okay, they will act on distal convoluted tubule. So next comes weak or adjunctive, supportive diuretics. Adjunctive diuretics. In that you have three categories. First one is carbonic anhydrase inhibitors. Okay, so that is what we call it as acetazolamide. Acetazolamide is carbonic anhydrase inhibitor. Okay, so what is carbonic anhydrase, and how it is involved in reabsorption of sodium, and why this enzyme has to be blocked, that I will discuss with the help of a neat and a clear diagram when I come to the individual diuretic. But right now, I will brief it out what is happening here. See, generally what happens inside your kidney. Inside your kidney, this is what we call it as blood. Okay, so suppose this is your blood, this is your cell, epithelial cell, and here this is your lumen, empty tube, empty tube. Okay, like this. Okay, this is your tube. So I am showing in this fashion. So like this. Okay, this becomes blood, this becomes cell, and this is the empty tube, lumen. Okay, so generally reabsorption occurs, reabsorption of sodium, if you consider how sodium will be reabsorbed or potassium will be reabsorbed in this fashion. First from lumen, it will enter into epithelial cell, sodium, and from epithelial cell, it will be reabsorbed in the blood. Okay, this is how reabsorption takes place. So now here why I am discussing this, in a simple manner, let me explain. Inside the epithelial cell of the nephron, what will happen? Carbon dioxide and water, generally. Carbon dioxide and water, so both will unite and there will be a formation of H2CO3. H2, sorry, yeah, H2CO3. H2CO3 is nothing but carbonic acid. Okay, and this reaction, carbon dioxide and water combining and forming carbonic acid, it is catalyzed by an enzyme which we call it as Ca. Ca is nothing but carbonic anhydrase. Carbonic anhydrase. I will show this picture very clearly. Don't worry. So, so what is the connection between formation of carbonic acid with the help of carbonic anhydrase and diuretic effect? Let me tell you. So carbonic acid again splits into two parts. Let me tell you. One is it splits into H plus and it also splits into HCO3 minus. HCO3, sorry, minus. HCO3 minus. H plus and HCO3 minus. So the point of matter here is HCO3 minus is absorbed in the blood. Okay. HCO3 minus is reabsorbed in the blood. Okay, that's fine. Then what is the why? What is the connection between diuresis here? The point of matter is when HCO3 is absorbed, it is absorbed along with sodium. Okay, even HCO3 is absorbed along with sodium. Sodium also gets absorbed along with HCO3. Okay, and the problem here is in case of hypertension, in case of edema, in case of congestive heart failure, there are many conditions where sodium accumulation leads to water accumulation, because both are connected. If sodium accumulates, water will also accumulate, and in those circumstances we have to remove sodium. Simultaneously water will also be eliminated through urine. So what we have to do, we should not allow the sodium to get reabsorbed. You have to eliminate the sodium. And diuretics, the major role of diuretics is to increase the excretion of sodium and water. So that's why what is happening here, these diuretics, carbonic anhydrase inhibitors, so carbonic anhydrase inhibitors, what they are doing, they are going to inhibit this enzyme Ca, that is carbonic anhydrase. Minus sign indicates inhibition. So when carbonic anhydrase is inhibitor, carbon dioxide and water, even though they unite, they won't, they doesn't gets converted into carbonic acid. Carbonic acid is not formed. When carbonic acid is not formed, bicarbonate HCO3 minus is not formed. Okay, when HCO3 minus is not formed, definitely HCO3 minus will not be absorbed, and when it is not absorbed, it doesn't take the help of sodium. Sodium is also not getting absorbed. Am I right? So thereby you are preventing the reabsorption of sodium. So that is the mechanism of action of carbonic anhydrase inhibitors like acetazolamide, that we will discuss when I come to the individual diuretic. Okay, and one of the major problem with diuretic is hypokalemia. One of the major side effect of diuretics, as we have discussed, it is hypokalemia. Do you know what is hypokalemia? Hypokalemia is decreased potassium levels in the blood. Okay, so why potassium levels decreases? The reason here is, please try to understand. So along with sodium, so first you should understand what are the things what are the ions whose excretion is facilitated by diuretics. By using diuretics, sodium will be excreted out, chloride will be excreted out, Cl minus. By using diuretics, water will be removed, H2O, and along with that, even H plus ion will also be excreted. H plus ion will also comes along with sodium and water, and also potassium will also come along with sodium and water. Okay, this is what happening. As a result, when you use thiazide diuretics or loop diuretics, one of the major side effect is hypokalemia, because because it increases the excretion of sodium and water, followed by even potassium is also going out. Am I right? So that is a problem. And you may ask the question, sir, why potassium is going out? There is a reason here. Let me show you a simple diagram. You will understand why potassium, why there is hypo, why there is hypokalemia with diuretics. Let me share you that. Just a minute. Sorry, not this one. Okay, just a minute. Yeah, I think this slide is visible to everyone. So please observe. Let me zoom it here. Slightly, I would like to zoom. Yeah, here you can see. So what happens here when you block the excretion of sodium? When you block the reabsorption of sodium in a particular part of the nephron, either it may be in ascending limb of loop of Henle or it may be in distal tubule. What happens? Large amount of sodium load. Please try to understand it. Large amount of sodium load will reach us here in this part. Am I right? Because the reabsorption which is occurring in PCT, reabsorption which is occurring in loop of Henle, reabsorption which is occurring in distal convoluted tubule, if you are going to block, that sodium load will be carried to the collecting duct. And here, when excess amount of sodium comes here in the collecting duct, that excess sodium load will trigger aldosterone, will trigger the release of aldosterone. Aldosterone will be released. Okay, is it clear? From adrenal cortex. From adrenal cortex, aldosterone will be released. Okay, and when aldosterone will be released here, what will happen? Aldosterone will start reabsorbing sodium and it will release potassium. Okay, so sodium reabsorption occurs followed by potassium excretion will occur. Okay, so however, sodium reabsorption doesn't get affected because your sodium load is very high here. Even certain amount of sodium, if it is reabsorbed, it doesn't disturb your diuresis. Okay, but the problem is if certain amount of sodium is reabsorbed, it releases a certain amount of potassium into your lumen. Okay, potassium will be released, and that potassium release will cause a severe problem because the potassium levels will fall down in your blood, and that is the reason behind hypokalemia. As a result, blood potassium levels will decrease. You can see the arrow mark here. So sodium is reabsorbed, okay, and here potassium is excreted out. Okay, along with sodium, sodium. So suppose you have, for example, some 50 sodium ions. Okay, 5 sodium ions will be reabsorbed. You have 45. 45 will be excreted. That's why diuresis will go on. But whatever the 5 sodium ions that are reabsorbed, in place of that, some 5 potassium ions will be released into your collecting duct. Okay, and this when it happens continuously, definitely there is a severe loss of potassium. Am I right? That is what we call it as hypokalemia. You can see here, enhanced sodium delivery results in potassium loss in the collecting duct, because in the collecting duct, when sodium load increases, sodium reabsorbs, aldosterone will be triggered, stimulated when sodium comes into the collecting duct. Okay, and aldosterone increases sodium reabsorption and it will release potassium. Okay, and potassium will come along with sodium. Okay, so because you may have a question, sir, when sodium is reabsorbed, what is the use of diuresis here? Sodium reabsorption is not high. Sodium reabsorption may occur, but that doesn't disturb your diuresis because the sodium load is very high. Out of 50 sodium ions, if 4 to 5 sodium ions are reabsorbed, that's not a big problem. Okay, so already you have enough sodium in your body. Your intention is to remove the sodium. That's why that slight reabsorption doesn't cause a problem. But compensating sodium reabsorption, potassium will be released out. Okay, and this potassium which comes out when sodium is reabsorbed, that will cause severe decrease in potassium levels in the blood. That is called hypokalemia. Okay, I think you got it. Yeah. So we will discuss when I discuss hydrates and loop diuretics. So I would like to share the previous screen. Yeah, coming back to our previous screen. So that is the problem. And as I told you, when these diuretics, as they are going to cause hypokalemia, you have to protect potassium. You have to protect potassium. Either you have to give potassium supplement to the patient, or you have to use such a diuretic which will conserve potassium, which will not allow the potassium to go to get to go out of your blood or to go out of your urine. Am I right? You have to protect the potassium. So that's why we are using potassium sparing diuretics. Here you can see this is potassium sparing diuretics, which is going to conserve potassium. And as I told you, heavy sodium load due to diuretics that reaches the collecting duct will trigger the stimulation of aldosterone, and aldosterone will reabsorb sodium and it will excrete potassium. That's why you are going to block the aldosterone by using a drug that is called spironolactone, and thereby you are preventing the reabsorption of sodium at the collecting duct, and thereby you are going to prevent the excretion of potassium. Okay. So next is inhibitors of renal epithelial sodium channel. Am I right? So this is also very important. So renal, these drugs, they will block sodium reabsorption by inhibiting renal epithelial sodium channel. Am I right? So sodium which is reabsorbed from lumen into the epithelial cell, and from epithelial cell sodium will be reabsorbed in the blood. So here sodium reabsorption from lumen into the epithelial cell will be blocked by these drugs that I will discuss. So these drugs are triamterene. So they are nothing but they are triamterene and they are amyloride. These two drugs are going to inhibit renal epithelial sodium channel. Thereby sodium reabsorption at the collecting duct is blocked, and thereby potassium excretion is also blocked. Potassium is also not excreted. Am I right? So thereby, so you can conserve potassium. And coming to last one, osmotic diuretic. This is also a weak diuretic. So this is going to modify the contents of the filtrate. Okay, I think you know osmosis. Osmosis is a condition where there is a movement of water from lower solute concentration to higher solute concentration. Am I right? Okay, so movement of water from lower solute concentration to higher solute concentration, or I can say that higher water concentration to lower water concentration. Right? Movement of a solute from higher water concentration to lower water concentration. Okay, so what happening here is these drugs like mannitol, isosorbide and glycerol, they are going to increase the uh, volume of the filtrate. They are going to modify the contents of the filtrate. They are going to make the contents of the filtrate very, very concentrated. Am I right? So for example, this is your renal tubule. Okay, and these are the cells. Okay, and here if I talk about sodium, Na plus, so absorption in this manner, sodium will enter into cell and then it is going to enter into blood. So why it is absorbing into the blood? The only reason is osmosis is going on in this direction. Okay, so you have to block this osmosis. You have to block the absorption of sodium into the cell and further into the blood. So for that, what we have to do? You have to increase the concentration of the filtrate here. So you have to increase the osmotic pressure here. For example, if you increase the osmotic pressure here, what will happen? So definitely, so water and sodium which is present from the blood, which is present in the blood, they will enter into the cell as a result of increased osmotic pressure. As a result of increased OP, osmotic pressure, so water will be attracted from blood into the epithelial cell. From epithelial cell, water will enter into the lumen. So this will happen only when you increase the osmotic pressure of the filtrate. Okay, but generally osmotic pressure of the filtrate will be less than the osmotic pressure of the blood. That's why reabsorption is going on in this direction. Okay, but if you increase the osmotic pressure of the filtrate, reabsorption occurs in this, reabsorption occurs in this direction. Okay, so this is how you have to, this is how these diuretics will work. They are going to increase the, modify the contents of the filtrate. They are going to increase osmotic pressure. Thereby, they are going to facilitate the facilitate the entry of water and sodium from blood into the lumen, so that large amount of sodium comes into the lumen, and that will be excreted in urine. That will be excreted in urine. So this is the mechanism of action of osmotic diuretics. Okay. Yeah. Okay, I will stop now. So we will continue our discussion in the next coming session. We will take individual diuretic and we will try to discuss it in detail. Okay. If you have any doubts regarding this, please bring to my notice. Okay. So please, yeah, this video will be displayed in your regular class. So watch the video and please note down what are the doubts that arises in your mind, and you can interact with me. Okay. Okay. Thank you.